Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. I want to talk to you guys a little bit today about atherosclerosis and heart disease. It's not a super sexy topic, but I want to share some things with you that I have a feeling many of you may not be aware of, and that really came as a revelation to me a number of years ago when I started learning about this stuff. I just finished up some ER shifts, and not surprisingly, I see a lot of heart disease that comes through the doors of the emergency room. In particular, I had two patients a few days ago that came in with heart attacks, and they were the kind of the typical sort of patient that you would expect to have heart disease. Both these guys were men over the age of 50. They were morbidly obese. They both smoked. They both had high cholesterol, very high blood pressure. They were, minimally compliant with their medications. None of them exercised, of course, and one of them regularly used methamphetamines. So, it wasn't surprising that these guys came in with a heart attack. I mean, they were sort of these guys are like the poster children for cardiovascular disease. But, every now and then we all hear stories about people who are fit and healthy, maybe even in their 30s, then they just drop dead suddenly from a heart attack. And they get an autopsy, and sure enough, they've got severe atherosclerotic heart disease. So what's going on with that? That's always has been kind of perplexing to me. And so that's what I want to talk with you about today, is kind of the natural history of atherosclerosis. And the two guys that came in both ended up having extensive coronary artery disease, multiple lesions, and but those lesions didn't pop up overnight. So that process started at some point in their life. And one of the things that I didn't realize until relatively recently was just how early atherosclerotic disease starts and how prevalent it is in the community. So what I'm going to share with you guys, and what I want you to think about, is odds are very high that you, as you sit here and watch this, you already have significant coronary artery disease. Odds are very high that I have significant coronary artery disease, even though I'm completely asymptomatic, and you may be as well. So let's talk about this a little bit more. I was always really interested in anthropology, when I was an undergrad student, and I still kind of am. This is a picture of Otzi the Iceman, who was found, I believe, way high up in the Swiss Alps, I think above 8,000 feet. And he died over 5,300 years ago. And out of sheer luck, because of the environmental conditions in which he died, his body was really well preserved. And so he's probably one of the most studied mummified ancient humans that have ever been found. And I believe he's actually the oldest mummy that has ever been found that had a large percentage of his soft tissues intact. So anthropologists and scientists were able to learn a lot from this guy. Interestingly enough, he didn't just die up in the mountains. He was actually murdered. It sounds like they think that he bled out from an arrow that was shot into his back and severed, I think they said, his subclavian artery, and so he bled out and died. And then he may have had a coup de grace with a blow to the head. So somebody was very upset with him at some point a very, very long time ago. But this is a reconstruction here of what they think he looked like. And I believe he was about 46 years old when he died. So this is a guy who was extremely physically active, who probably had been up and down the Swiss Alps, his entire life. He ate a completely natural, unprocessed diet, because processed foods really didn't exist at that point in time. He was very lean. He was very muscular. Like I said, otherwise kind of, I wouldn't say the picture of health, but you wouldn't expect this guy to have significant coronary artery disease, which is often thought of as a modern problem. Well, it turns out that he did, and on his autopsy and on the CAT scan imaging that was done, it turned out he had I believe it was 3 areas of calcified coronary plaque involving his heart, and then he had calcifications in his aorta and one of his iliac arteries as well at the age of 46, which was kind of an unexpected finding. But as we'll talk about, maybe it wasn't as unexpected as we might think. So it turns out that coronary artery disease, or atherosclerosis in general, it's actually extremely common in ancient populations. Again, we have this sometimes we have a tendency, especially like the paleo crowd, to kind of like idealize the past, that humans were so much healthier and much more fit back in the Paleolithic time, when we ate a natural diet and we were physically active. And they're partially correct, but this is a really interesting paper from the journal Global Heart. It was written back in 2014, and the title is "Why Did Ancient People Have Atherosclerosis?" And they talk about the autopsies and CT scans of multiple different mummified human remains from all over the world. So like Egypt, Peru, the Aleutian Islands, they said, the Southwest United States. So people that had died thousands of years ago in some cases, and whose bodies were really well preserved. Well, so these people lived in vastly different geographic areas. They ate different diets, but obviously ate a lot of raw food and unprocessed food, just like Otzi did. And they were physically fit. Nobody was obese. Obesity really didn't exist back in those days to any significant extent. So, but it turns out many, in fact, not just many, but most of these mummified remains, which typically were in their 40s when they died, some older, some younger, but almost all of them had some degree of atherosclerotic disease, which is really interesting. And so this paper talks about some of the reasons why that might be the case, and they put out a few theories. We do know that atherosclerosis is it's an inflammatory disease, and so they speculated that these people likely suffered from chronic inflammation, not for the reasons that we do today. Like today, visceral body fat obviously is a huge contributor to chronic inflammation and a number of other different things. But, these human populations were infested with parasites. They had, chronic mycobacterial infections. They likely had bad periodontal disease. So they had a lot of reasons to have chronic inflammation, which I think may have driven this atherosclerotic process. Many of them had evidence, and I believe Otzi did too, of living or spending a significant amount of time around fire and smoke, probably with indoor fires in their huts and other shelters where the air quality wasn't quite that good. So maybe that just like smoking cigarettes may have accelerated their development of atherosclerosis, and probably did contribute to inflammation. And then obviously genetics play a big role in heart disease. We know that in modern day populations too. Otzi was found to be homozygous actually for a particular allele which is strongly associated with early atherosclerosis, and it turns out aortic abdominal aneurysm as well. So even if he had escaped, whoever was chasing him up there in the mountains, it's likely that he would have potentially died eventually, likely of coronary artery disease or atherosclerosis, so heart attack or a stroke, just based on his genetics. And interestingly enough, the paper talks about they found 19 people that lived in that general area of Europe that were considered to be direct descendants of his. So, possibly he passed on those unfavorable genes to those 19 people. I think if I was one of those people, I'd probably want to go get checked. The development of atherosclerosis, in my opinion, seems to be it's tied into being a human being. And clearly we can do things and make choices that will make this much worse. We can also make choices that can make it a lot better. But it may not be possible to entirely avoid it. And so I'm going to talk about that a little bit today too. So this slide here, this is just a visual of the development of atherosclerotic plaque over the years. And pathologists grade these plaques, they use a numeric scoring system from 1 to 8. And but what I want to focus on here is, early on here, this is a healthy vessel here. There's basically nothing going on. But if you look at the microscopic level, there's going to be some inflammatory changes there, some macrophages that have started to infiltrate the lining of the vessel. And then as time goes on, they will accumulate. You'll see these little microscopic, fatty streaks. that progresses on to, so that would be like a stage 2 lesion, and then you start getting into stage 3, which they consider an intermediate lesion, and now you've got much more extensive like lipid accumulation, but still nothing that's like an actual like plaque, an atherosclerotic plaque that we would recognize as something to be overly concerned about. But eventually you get to this what's called a stage 4 plaque, which is an atheroma, and this is where you start to see, okay, this is starting to look like a real atherosclerotic plaque, right? Because there's this core of extracellular lipid that just accumulates, and we're starting to develop a little bit of a fibrous cap there. And then as time goes on, that lipid core gets bigger, the fibrous cap continues to develop. Meanwhile, the lumen of the artery is progressively getting more and more narrow, but you're not likely to have any symptoms there. Even with a 50% narrowing of your artery, that's likely in most people to be asymptomatic. Even when they exert themselves, to extreme levels, there's still enough patency there to get adequate blood flow to your heart and other tissues. And then here at the end, you have this very large plaque. This may be a 50 to 70% lesion. You have an inflamed fibrous cap, and then a clinical event, meaning a heart attack or stroke, happens when this fibrous cap ruptures and this lipid core is exposed to the tissue. The body senses that as an injury, and the coagulation cascade kicks in. You get platelet accumulation, and you'll go from a 50 to 70% lesion, for example, to 100%, complete occlusion of the artery as a result of that thrombus that's there, and then you have your clinical event, which again, heart attack, stroke, etc. So when does this initial lesion here, this fatty streak, and then this atheroma, these kind of early changes, when do we start seeing those? I always thought these probably happen like later in life. Maybe in your 30s is when this starts to happen. Turns out I was incorrect about that. So this is a paper here, lipid and macrophage accumulations in arteries of children and the development of atherosclerosis. It's the American Journal of Clinical Nutrition from 2000, and this is really shocking, actually. What they talk about here, the opening line of the abstract, about 1/2 of infants in the first 6 months of life have small collections of macrophages, and macrophages filled with lipid droplets, which those are called foam cells, which form the, sort of one of the key components of an atherosclerotic plaque is a foam cell. So 1/2 of infants under 6 months of age have a detectable quantity of foam cells in certain areas of their coronary arteries, which is crazy. And then things kind of progress from there. They talk about around puberty, which they define as age 12 to 15, foam cell accumulations, mostly larger than those in infants, occur in 69% of adolescents. Okay, these sort of, they say pre-atheroma lesions contain small pools of lipid droplets and dead cell fragments, in addition to macrophages from foam cells. As they progress, they say here in the age group of age 16 to 19, 15% of persons have either pre-atheromas or atheromas in their coronary arteries. So we're talking like stage 3 to stage 4 lesions, which are well advanced, down the road to a significant atherosclerotic plaque. Certainly once you reach stage 4, when you get to that atheroma, you are well on your way. The disease of atherosclerosis at that point has a very strong foothold in the artery. And that's in 16 to 19-year-olds, so teenagers who, should be the picture of health. Now, I'm not saying that these are not symptomatic. There's no symptoms from this, but this is this silent disease that is in the background and over years and decades continues to progress. So this is a very telling chart here from this paper. And what I want you to focus on is this bottom line here. The other ones are a little bit less relevant so this is the rate of these stage 3 and stage 4 or 5, in this case, lesions. And you can see like early childhood and infancy, like that line is really, it's flat. You're not going to see those kind of more advanced lesions. But after age 11, all of a sudden, now again, age 11, it starts to pick up, and you can see it picking up here. And by the time you're in the age of 20 to 23, you're looking at about a 15+% prevalence. And then when you get up to age 28 to 31, we'll come up here. This is about It's about 35+%. So, over a third of 28 to 31-year-olds have some of these more advanced lesions. And then when you get up here to age 36 to 39, which is still really young, you're close to 70%. 70% of individuals have these advanced, stage 3 to stage 5 atherosclerotic lesions in their coronary arteries. Again, they're asymptomatic, but that is a serious amount of atherosclerosis for somebody who's so young. Not the typical person that you would think is going to drop dead from a heart attack. Okay, and then this is a chart here, prevalence of atherosclerosis and coronary heart disease by intravenous ultrasound. So they put an ultrasound probe into the vessel, and you get a really good look at the health of the artery. And wow, so age 13 to 19, they found a 17% prevalence for a significant atherosclerotic disease, and you can see the numbers there. It just goes up and up and up. And by the time you're over the age of 50, 85% of individuals. Age 40 to 49, 71% of individuals already have a significant amount of atherosclerosis detectable on ultrasound. So this process that leads to heart attack and stroke, later on in life, it gets started in childhood. Okay, so that's why I'm saying this may just be part of the human condition. And it also tells me that there's a lot more that we need to learn about heart disease and just atherosclerosis in general. We don't have all the answers to this and to why this happens. And I think what we're going to find as time goes on is that there's going to be a lot of previously unknown genetic factors, and I suspect environmental factors that we're yet unaware of that are driving this process. But it starts very, very young. This article here, I was actually aware of this article and I kind of completely forgot about it. I went to a military medical school, so we talked about some of the autopsy studies that were done on like Korean War and Korean and Vietnam War casualties. So very young people, in their early 20s who were very physically fit, who died in combat and had autopsies done, and the high prevalence of asymptomatic atherosclerotic coronary disease that was found. They mentioned it here in the abstract. Autopsies performed on casualties of the Korean War revealed coronary artery involvement in 77.3% of the hearts that were studied. And then the Vietnam one, they mentioned it was lower. It was 45% of casualties had severe disease in 5% of those. So this study here in the Journal of the American College of Cardiology, it's an older study from 1993, but obviously still completely valid. It's called Manifestations of Coronary Atherosclerosis in Young Trauma Victims. This is in the United States. It was these people didn't die in combat, but they died from other traumatic conditions. And they looked at 111 victims of non-cardiac trauma. Average age was 26 years old, plus or minus 6 years. So again, a very young, presumably otherwise healthy population. And they found, 78.3 had some degree of coronary atherosclerosis. But here's what's even scarier. 20.7% had over 50%, at least one artery that had over 50% narrowing. So those are the lesions that are really, that's a high risk lesion, around 50%. It's not necessarily that old calcified, like 80% plaque that's just sitting there like hard as a rock. It's this fleshy, perhaps minimally calcified and inflamed plaque that's at 45 or 50% that may be more prone to rupture. And basically 21% of these young individuals that died for other reasons had one of those lesions. And then 9% of them had at least one lesion that was greater than 75%. So, I mean, shocking, right? Shockingly extensive coronary disease for people that we would think would not be at risk for something like this, and, who presumably are otherwise healthy. Okay, so what do we do about this? Well, nobody knows. Nobody knows. I mean, ultimately, nobody knows. But this is a good article that at least makes an attempt to try to explain that question and present options. And this is from the European Society of Cardiology, published in 2020. Subclinical atherosclerosis, how and when to treat it? It's a great question. Vast majority of lipidologists, cardiologists, and physicians, they're not recommending that we put children on statins, obviously, for obvious reasons. with the exception of, children that may have, homozygous familial hypercholesterolemia, because they do die in their teens and 20s from coronary artery disease. So, not including that population, nobody short of like certain pharma executives and maybe there's a few rogue cardiologists out there that think we should put statins in the water. Nobody's advising that we put children on statin medications. But, we do know that this disease starts in childhood. So, there needs to be some sort of intervention done, in my opinion, even at that early age, to address that, or to at least slow that process down. But one of the interesting things they talk about in this article is, okay, well, how do you evaluate somebody for subclinical atherosclerosis? Because remember, it's subclinical, right? There's no symptoms. So there's a number of different imaging modalities, and they've come a long way, in the last few years. They mention probably one of the more common and popular ways to measure coronary atherosclerosis, and that's with a calcium score, which is a CT scan done with special software, and it can be a useful test in some cases, but it has some obvious limitations I'll talk about here in a second. But in general, if you have a very low calcium score, that does correlate with the extent of atherosclerotic disease. The problem with detecting subclinical atherosclerosis in young people using a calcium score is that the deposition of calcium into an atherosclerotic plaque is something that tends to happen much later in the progression of the disease. So young people with coronary plaque tend to have soft plaque that has yet to calcify. And so if we're looking for calcium, you're not going to find it in these lesions. So you may have a coronary calcium score of 0, and you can feel pretty good about that in general, but that doesn't mean you don't have atherosclerotic disease. So when I turned 40, I got a calcium scan, because the men in my family tend to drop dead around 50, slightly less, from coronary artery disease, and it was 0, which was cool. But what I really would have liked to have was a CT coronary angiogram, which wasn't available back then. But I'm going to be turning 50 here in a few months, so I will be getting a CTA, and I'll post the results of that for you guys. And that is a much more useful test, because obviously you can see calcified plaque, but you can also get a good look at soft plaque, and get a really detailed look at the anatomy. I think it can be a very useful test in certain circumstances. It's way more expensive. It's not something that financially can be supported, I think, across the population for everybody. But if you have a family history like I do, and additionally I have very high lipoprotein A, so I know that I have some degree of coronary plaque. I just don't know how extensive it is. So I would like to know that, and so I'm going to find out here in a few months, and I'll let you guys know. Other options, you can look at something called a carotid intimal media thickness, where you take an ultrasound and you look at the carotid arteries. That can be useful. It's non-invasive. It's relatively inexpensive. But the CTA, I think, is becoming more and more the gold standard, for evaluating this condition. Your routine stress test that you get from your doctor, whether it's like the old school Bruce protocol GXT, or whether you're getting a stress echo or a thallium, adenosine cardiolite, whatever the case may be, are actually quite poor at detecting subclinical atherosclerosis, because again, you have to have a relatively advanced coronary lesion that limits blood flow to a significant extent in order for those tests to be useful. And many people with atherosclerosis, like I said, they run around with 40 or 50% lesions. They can pass a stress test with flying colors, and then drop dead from a heart attack the very next day, which I actually have seen one time. So I don't put a lot of faith in routine stress tests. If somebody comes into the ER with classic anginal symptoms and they had a stress test, let's say 3 months ago, that was completely normal, I'm still not sending that patient home, without a much more thorough evaluation, because I just don't put a lot of stock into that negative stress test. So one of the things they talk about in this study, of course, is addressing cardiac risk factors, and they're all the things that you would expect. This is a study, coronary heart disease risk factors ranked by importance, from the European Journal. This is from the European Heart Journal. It's a little bit older, at 2002, but it puts in rank order according to their analysis, what the most important coronary artery disease risk factors are. And they're the things that you would expect. So we'll focus here on men. This is a men's channel. Type 2 diabetes, well, they just say diabetes mellitus, so type 1 or type 2. Hypertension, smoking, physical activity. Interestingly enough, no daily alcohol intake was considered a risk. That's actually been debunked. Hypercholesterolemia, obesity, and then socioeconomic status, and education does matter, as well as hypertriglyceridemia. But one of the things I always harp about on this channel is the importance of addressing obesity and getting your body fat and getting your body composition as optimal as possible, which is probably somewhere around a body fat percentage of 10 to 15% for most men. So look at these risk factors: diabetes, hypertension, physical inactivity, hypercholesterolemia, obesity, and hypertriglyceridemia. If you do the things that you need to do to get a, let's say, 12% body fat, you have probably addressed all of those, significantly. You made significant strides in improving all of those ones I just mentioned. So that alone, just by doing that, is going to significantly lower your risk of heart disease. And, for God's sakes, like, if you smoke, I don't even know what to say to you at this point. Like, what are you doing? What do you do? Stop. This is a huge risk factor for cardiac disease, not to mention cancer. It's crazy, like, how many people I see in the emergency room on a daily basis that still smoke cigarettes, and in many cases they're young people. So, like, it's not like they don't know better. The other thing that they mentioned in this article is that, and this is really important. This is why you have to start early with this stuff. These the early atherosclerotic plaques, so the stage like 1 to 3, before you start developing that thicker fibrous cap and you have that big lipid core. Those sorts of lesions, it is possible to, if you get very aggressive with your risk factor modification and lifestyle, it is possible to regress those lesions and in some cases make them disappear entirely. Once you're at stage 4 and higher, you certainly can make some significant progress and you can reduce the size of those lesions, but it's very, very challenging to make them go away completely. So you have to start addressing these lifestyle factors very, very early in life. And, unfortunately, that most people don't start addressing these risk factors, from what I've seen, until they've had a clinical event, or they've had some sort of a scare, maybe in their 40s or 50s, at which point their disease is well advanced. They're well down the road. And, at that point, many times the best they can do is slow the progression, and in an ideal world they can just halt the progression, and it's very difficult to reverse those sorts of lesions, although it's not impossible. So I mentioned low body fat percentage. Diet plays a huge role in this. The bulk of the data out there's obviously a lot of controversy about this, but the Mediterranean diet seems to have the most favorable risk profile to it, but that's controversial. There are other diets out there that have good data with them too, everything from vegan to ketogenic diets. But the Mediterranean diet is generally what I recommend, and it's ultimately the diet that you should be on is the one that you can stick with and the one that keeps your body composition in the most favorable zone. So a Mediterranean diet, a lot of people are like, well, what is that? Well, it's a diet it's high in polyunsaturated and monounsaturated fats, typically from like a lot of olive oil. It's relatively high in like whole grains, legumes, nuts, which again are excellent source of unsaturated fats. It's low to moderate red meat intake. It's not zero red meat. There tends to be a lot of oily fish, which is not only delicious but good for you, and a low to moderate amount of like dairy products and things like that. So that's the diet for most people that I generally recommend. It's a diet that I try to follow most of the year, with the exception of times when I try to get really, really shredded and lean, in which case I prefer to go on a ketogenic diet, and that's usually only for like 12 to maybe 16 weeks at a time. But in general, I try to eat a Mediterranean diet because I think it has the most data behind it, and I like that kind of food. So let's say you are doing everything right. Is that enough? And that's a great question. And the answer is maybe, but maybe not. And this paper right here, this is why I say that we don't have all the answers in coronary artery disease. We think we know what the major risk factors are. We have some treatment modalities out there, but this paper to me it shows exactly the fact that we've got a lot to learn about this condition. And like I said before, I suspect that we're going to find a large number of genetic factors and a large number of as yet undiscovered environmental factors that are driving this disease. So this is a great paper. So it's from the Journal of the American College of Cardiology, 2017. Normal LDL cholesterol levels are associated with subclinical atherosclerosis in the absence of risk factors. Okay, so I'll boil this down for you here. So they had two different groups of patients. I'm only going to focus on the healthiest one because that's what really matters. So they found a group of people, 740 of them. Average age was 45 years old, plus or minus 4.1 years. Half of them were women. So these are people that had sort of optimal risk factors, or what they consider to be optimal risk factors. And so what they meant by that is their blood pressure was excellent. It was under 120/80. They had a fasting blood sugar under 100. They had a total cholesterol under 200. And so, that's the goal, right? That's presumably, if you have that, you really shouldn't be at risk for atherosclerosis. Well, unfortunately, it turned out that 37.8 of those had significant amounts of atherosclerotic disease, despite having on paper, looking pretty darn good. Now, I will say, did they look at every possible risk factor in these people? Not necessarily. I mean, they looked at their total LDLs, and we'll talk about that in a second. They didn't fractionate their LDLs, so we don't really know, like, these high density, small, slightly more atherogenic LDLs. They didn't test for lipoprotein A. They didn't see how many large fluffy LDLs, which are thought to be less atherogenic. They didn't do any of that. They didn't look at chronic inflammation, so they didn't measure high sensitivity CRP. But regardless of that, these folks, they still had like a really high incidence of coronary artery disease, and that was much better than the background population. And we saw in those other studies, people in their mid 40s, we're talking like 50 to 75% prevalence of coronary disease. So these risk factors do matter. The rate was only 37.8% in this case, but that's still, over a third of those people with perfect numbers, or what is considered to be perfect numbers, still had significant coronary artery disease. So they go on to say here, independent risk factors for the presence and extent of subclinical atherosclerosis were age, male sex, I mean, we've known that for a long time, and a basal value of LDL cholesterol. Okay, so I'm going to talk about that a little bit more in a second. In particular, they found a linear relationship between LDL values and the increase in the prevalence of subclinical atherosclerosis, which went from 11% in this subgroup of 740 patients. So the patients with the very low LDL levels, like between 60 and 70, which would make most cardiologists pretty happy, they had a rate of atherosclerosis that was about 11%. And then if you had an LDL between 150 and 160, the rate of atherosclerosis jumped up to 64% in those individuals. Okay, so there are still a lot of people out there, even physicians, that I see like on social media and YouTube, that really downplay the role of LDL in as a causal agent in atherosclerotic disease, and unfortunately I understand that they tend to focus on the other risk factors, inflammation, all those sorts of things, and I'm not denying the fact that all of those are extremely important, but the data is pretty damn clear that LDL cholesterol is extraordinarly important. It's probably one of the most important risk factors for the development of coronary artery disease. I know that like people like to quibble about particle size and things like that, and I do get particle studies. I get NMR lipid panels on many of my patients, but you'll see it sometimes like in the keto and the carnivore world. They'll say, hey, listen, I know my LDL is through the roof, it's 180, whatever the case may be, but according to this NMR lipid profile, my the vast majority of my LDL is this large fluffy LDL which, is not known to stick to the artery wall and doesn't contribute to atherosclerosis. Well, that's not really true. They're correct in that it is less atherogenic, but it's not zero atherogenic. So, the particle number matters, even if it is this large, fluffy LDL. I mean, given the choice, I would rather have that sort of a pattern versus a small, dense LDL pattern, right? But the fact is that even having that more favorable pattern, it doesn't give you a pass. Like you can still develop atherosclerotic disease from those particles. It's just a little less atherogenic than some of the other types of LDL that are smaller and more dense. So LDL does matter. And this is a good chart from the paper I just showed you that I thought was pretty interesting. So at the bottom here, they separated out all of the patients based on just based on their LDL. They didn't look at anything else. And it shows the number. So all the way over here on the left, if there were only two patients that had baseline LDLs of 50 to 60, naturally without being on a statin. And it's only two patients, so I don't know how much you can read into that, but they had no atherosclerosis. So presumably these people had very favorable genetics, and there was no atherosclerosis found. But as the LDL level increased above 60, you start seeing on the top of this graph here that the number of people that had atherosclerosis starts to go up. And the number of people that had it in more than one vascular site also goes up. So when you go up to like 90 to 100, which is, under 100 used to be what was typically recommended, granted, there's still a large percentage of people here, it looks about 60%, with no atherosclerosis, which is great. But there's still a significant amount that had atherosclerosis in more than one artery. And then as you go further to the right, you start seeing that the number of people with multivessel disease starts to go up. But again, what's interesting here too is that even with these sort of high LDLs in the 150 to 160 range, there was still, it's probably just under 40% that had no evidence of atherosclerosis whatsoever. So, I understand there's a lot more to atherosclerosis than just LDL. I mean, I don't want you guys to think that that's what I'm saying, but LDL is crucially important. It is probably the primary driver of atherosclerotic disease, but it's not the only one, because clearly, these people here with 150 to 160 LDLs, there's a large percentage of them that don't have any identifiable coronary artery disease. But there's a lot of them that do. In fact, there's a lot of them that had generalized atherosclerosis, which is this blue, 12 of them. This is atherosclerosis in 4 to 6 sites. So there's a direct linear relationship between LDL and the prevalence of atherosclerotic disease. It's not the only factor. So, my approach to addressing atherosclerosis is obviously LDL centered, but it doesn't ignore chronic inflammation, it doesn't ignore blood pressure, it doesn't ignore metabolic syndrome and hyperinsulinemia and all these other things that are contributing factors. And again, there are genetic factors that I'm sure we're not aware of yet, and very likely there's going to be other environmental factors that, as time goes on, we'll become more aware of that. So, all right. Okay, so what's the take home from this? So atherosclerosis is extraordinarily common. And the disease of atherosclerosis, it takes a foothold in your body essentially in childhood. So again, that's why I think this might be just part and parcel of being a human being. But the implications of that is that if we want to slow the progression of coronary artery disease or just atherosclerosis in general, you have to start very early in life with a very very healthy lifestyle. And that's the cornerstone of therapy. Nobody's talking about, I certainly wouldn't advise, putting, children and teenagers on statins, except in very rare circumstances, as I mentioned earlier. So the cornerstone is going to be healthy lifestyle. It's very difficult to stop and reverse established heart disease. So you want to do what you can when you have stage 1, 2, and 3 lesions, like we talked about before. You want to do what you can to reverse those, or at the very least to stabilize those. And if you have one of these more advanced lesions, it's not impossible to stop the progression of those lesions, but it's much more difficult. And again, this is a controversial statement. I'd refer you to some of the videos out there with Alan Snyderman, who's a well-known lipidologist who's been doing research in this field for a long time. Peter Attia has had him on the show a few times. But, if we're going to completely stop the progression of coronary artery disease in an individual, it's probably going to require lowering ApoB down to very, very low levels that probably are not achievable without some sort of pharmacological intervention, which I hate to say it makes me uncomfortable to say that, but that may be the reality of human physiology, is that if you truly want to stop this disease in its tracks, in addition to doing all the other lifestyle things, you may need to be on a medication to get your ApoB levels down as low as possible, maybe down as low as even 30, to halt the disease in its tracks. So when to start that is totally, it's up in the air. I don't have an answer for that. One of the things that could be helpful is to get one of these more advanced imaging studies, like a coronary CTA. And if you're one of these lucky individuals that has completely clean coronaries, well, I think you can make a case at that point, for not starting pharmacotherapy. And I don't think I would, if I had a completely clean CTA. But the odds are that you probably don't have a completely clean CTA, and then you've got to make a decision about how aggressive you want to be, because it's very likely that disease, as you get older, is going to progress. Now, it doesn't mean it's going to kill you. If you can get it under control and you can get it to just sort of trickle along and slowly get worse, and maybe you'll die of cancer, maybe you'll get hit by a bus, or you'll die from some other reason or some other cause. But it's this is a tough one. And I don't have good answers yet. I'm not on a statin currently, and all of my other cardiac risk factors are quite good. But if this CTA that I'm going to be doing here in a few months comes back with significant amount of disease, which it might, given my family history, I'm going to have to rethink my approach. And I don't have a problem with getting on a statin or even a PCSK9 inhibitor, or whatever the case may be, even though the thought of being on a medication, for the next 40 years of my life, and some of the implications of that, I'm not super excited about. But regardless, I hope you found this helpful. Again, with these complex problems, I think it's very important to stick with the basics. And the basics have always been healthy diet, lifestyle, optimal body composition, regular exercise. Those are things that you don't need a medication for those. It requires discipline, fortitude, and a bit of education on your part. And I'd finish by saying, if you're a parent, this is something that you need to start with your children quite early. If you're a parent who has an obese child, you're failing. You're failing in that regard. And, your child is at higher risk for development of atherosclerosis, as we've proven, with some of these studies. So it's not just that you have to do it. You have to set a good example, and you have to help them as well, if you want them to hopefully avoid some of these problems down the road. All right, guys, that's all I got for you today. I hope you enjoyed that. I will catch you next time.